All right, so this is the recap of the angina portion, coronary vascular disease, coronary artery disease. There's our objectives. So coronary artery disease is the most common type. It's basically atherosclerosis, hardening of the arteries of the heart, abnormal accumulation of lipid, fatty substances, and then they block and narrow the heart. So if you want to see the pathophysiology from Khan Academy, there it is. There's some facts. Basically, a lot of people have heart disease. Your non-modifiable risk factors: age, gender, ethnicity, and a family history with first-degree relative who had a premature diagnosis, because if we all live long enough, we will have some form of heart disease, so before 50. Modifiable things that you can fix is diabetes type 2, hypertension, smoking, drugs, excessive alcohol, obesity, physical inactivity, and cholesterol issues. There are a certain group of metabolic abnormalities known as metabolic syndrome, and if you have been diagnosed as having metabolic syndrome, then your risk factor increases for coronary artery disease. So you need 3 of the following, which is resistant to insulin, abdominal obesity, dyslipidemia, high blood pressure, a pro-inflammatory state, which is an increased C-reactive protein, and a prothrombotic state, which means that your blood is like hypercoagulable. So signs and symptoms of atherosclerosis, they're going to be dependent on the amount of blood flow that is impeded to the heart muscle. Your heart is not adequately oxygenated, and that's why you have cardiac muscle death. It can be called ischemia, chest pain, angina. If you have a significant blood supply loss or significant obstruction, it can lead to MI. Heart damage can cause a low cardiac output, which leads to heart failure. So a risk factor for heart failure is myocardial infarction. Now remember, we're talking about stable versus unstable. So stable is going to be resolved with rest and nitroglycerin. Unstable is not resolved. It's going to be resolved with opiates, and it's not cured with opiates. It's going to get better with opiates. When the opiates wear off, then you're going to have pain again until the situation is fixed, and the only way to fix it is surgical intervention. Some classic signs and symptoms of cardiac cell death: the crushing chest pain, shortness of breath, fatigue, diaphoresis, nausea, vomiting. Remember that the pain of an MI is differentiated from stable angina by the persistence of the pain and if it fixes with rest or nitroglycerin. Women are going to have non-specific symptoms. Elderly can have silent coronary artery disease, and diabetics can have dull pain. So controlling cholesterol abnormalities, high cholesterol, there's a table in your book on page 401. You want to manage hypertension and control diabetes. So we talked today in class about statins, which are really HMG CoA reductase inhibitors, but it's much easier just to call them statins. The big thing that you need to remember with statins is that they affect the liver. So if you have liver disease that's active or chronic, you probably shouldn't be on a statin. Your side effects are elevated liver enzymes, myopathy, and rhabdomyolysis, so basically the body eating itself. So you need to, well, you don't, but whoever the provider is going to check the liver enzymes when they first get put on the medicine, and then they're going to base whether or not they stay on the medicine on symptoms. So if the patient starts having some abdominal pain, starts having dark-colored urine, muscle fatigue, muscle aches, they might take them off the statin and put them on some other kind of cholesterol-lowering medicine. Another medicine is called nicotinic acid. An example is niacin. The big side effect with niacin is flushing and elevated glucose. You can also have some hepatotoxicity with it. Your, again, contraindications are liver disease. Severe gout can be contraindicated with it as well. Fibric acid is another cholesterol-lowering medicine. The example is fenofibrate, so it causes dyspepsia, gallstones, myopathy. It can also have unexplained non-congenital heart disease deaths. The absolute contraindication with that, again, is liver disease, but it's also can be used in renal disease. Then we have our bile acid sequestrants, and basically these are going to work in your stomach. So they're going to get rid of the cholesterol through feces. So you're going to have a lot of abdominal symptoms. So GI distress, constipation, absorption of other drugs is decreased. So this is the medicine that you do not want the patient to be on if there's a familial history of elevated triglycerides. It's called dys-beta lipoproteinemia. So basically, angina pectoris is pretty much the same thing. It's the need for oxygen that exceeds the supply, and the severity is going to depend on the effect of ADLs on your oxygen level and the precipitating event. There's different types of angina: stable, unstable, and intractable, variant, and then there's silent, which is pretty self-explanatory. Intractable means like the pain doesn't stop. Variant is causes a, like you'll see ST elevation. You will have ST elevation, but it's reversible, and there will be no like ischemia afterwards. It's thought to be caused by coronary artery vasospasm. Again, the patho is pretty much the same thing. So, going to have a blockage in your coronary artery, and you can't get oxygen to your tissues. So again, this is just a chart to show you how oxygen supply affects chest pain. So coronary blood flow decreases, and that causes chest pain. O2 consumption increases, and that can cause chest pain. Another picture for you. Signs and symptoms. Again, you're going to have the indigestion, choking, heavy sensation in the upper chest. It can radiate neck, jaw, shoulders, tightness, heaviness, choking, strangling sensation. And you could also have weakness, numbness in your arms, hands, shortness of breath, pallor, diaphoresis, anxiety, dizziness, or lightheadedness. So if it's stable, again, it's going to subside with rest or nitroglycerin administration. Again, remember that your populations that are going to have irregular signs and symptoms, so your diabetics might just have adult pain, your women are going to have different symptoms. This is why more women die from MIs than men. And your elderly population might not even know that they're having chest pain. So I have PQRST for assessing angina, but you can also use OLDCART, which stands for onset, location, duration, characteristics, aggravating or relieving factors, and treatment. Your management of this is to decrease the oxygen demand of the heart muscle while increasing the supply of oxygen. So the way we do that is we give pharmacy, we give oxygen, and we reperfuse as needed. So if it's an unstable angina, we're going to reperfuse them. Again, the big difference between stable and unstable: exertional stress related happens with stable, rest or nitroglycerin relieves it with stable, and it lasts less than 15 minutes. With myocardial, it's going to happen any time of day, and for any reason. You could just be sitting there and you're going to have chest pain. It's only relieved by opioids. It lasts more than 30 minutes, and you have associated symptoms with it. Your tests that are specific to heart cell damage are your myoglobin, creatinine kinase, and your troponins. Diagnostic procedures are your EKG, which is like the window into the heart. It looks at the electrical activity. The stress test is not emergent, but it is something that they will test to see if, like, how bad the damage is basically after the fact, or you might have like an anginal episode going on and they admit you to the hospital, but they don't really see anything on EKG or your labs, and so they do a stress test the next day just to see what's going on. The thallium scan is a scan that you're not supposed to have stimulants 4 hours beforehand or smoke 4 hours beforehand, and it looks for ischemia. And then for the angina, if they aren't 100%, even if it is stable, they'll sometimes do a heart cath, which we didn't really talk about. Just know that it is a diagnostic procedure. You have certain pharmacy for angina, which are your inotropes and your chronotropes. Remember that your inotropes will be the force of the contraction. They affect the contractility of the heart, and your chronotropes affect the rhythm, like the heart rate. It doesn't really matter if the medicine is a positive or negative. I just want you to know what those words mean so that if you come across them, you can distinguish. So vasodilators, your big one with angina is nitroglycerin. It's going to prevent spasms in your coronary arteries. It's going to decrease your preload, afterload. It's going to decrease your oxygen. So you want to ensure that you use it cautiously with other blood pressure medicines because it can make you very hypotensive. Some of the big side effects with nitroglycerin: flushing, headache, the hypotension, the tachycardia. Those are things that you'd want to explain to your patient, that these can happen when you take it. Other education points that you want to give to somebody who's going to be taking nitroglycerin home is that you want to keep it in its original container. You want to carry it with you at all times. It can be inactivated by light, heat, moisture, and time. So it's only good for 6 months. After that, you need to get a new prescription. It should be taken, if you have stable angina, you want to take it in anticipation of any type of activity. You want to recommend that the patient describes times how long it takes to relieve their chest pain, because if it's stable angina and it's taken a little bit, you would want to let your provider know or the nurse know, like you had a triage nurse at your doctor's office. And you want to tell the patient to sit down when they're taking this because, again, it can bottom your pressure out and you don't want your patient falling out on you. Other medicines that are used in angina is beta blockers. They decrease the heart rate, slow conduction of impulses, decrease blood pressure, reduce heart muscle contractility. This causes a balance of heart muscle demands, and the supply of O2 is more available. So with beta blockers, the considerations that you want to think about is that a beta blocker is blocking your beta cells of your heart, so it's going to decrease your heart rate as well as your blood pressure. So you want to make sure that you take your pulse and blood pressure immediately before taking it. If a patient is on a beta blocker, you want to advise them to get their blood pressure regularly checked, and you want to tell them to follow the provider's instructions for the medicine, increasing the medication dosage. Calcium channel blockers decrease the pacemaker of our heart, which is the SA node and the AV node. This causes lower heart rate and decreases the contraction of the heart muscle. Thus, our workload is decreased, our blood pressure is decreased, and we have an increase in our coronary artery perfusion from relaxed blood vessels. The most important thing to remember with calcium channel blockers, other than the fact that your heart rate and your blood pressure are lower, is that you will also need to not drink grapefruit juice. So antiplatelet agents such as aspirin and Plavix, they help keep platelets from forming together. So if your patient is on an antiplatelet medicine, you want to make them aware that they're at an increased risk of bleeding, because platelets help clump up and clot. They help our clotting. So if our platelets do not clump together, then we don't clot as well, therefore we bleed more. So some of the considerations that we want to let our patients know is they're going to be on bleeding precautions. So we want to apply pressure longer to any injections. Don't want to give them IM injections. Hospital, we're going to monitor them for bleeding. So like low blood pressure, increased heart rate, and a low H&H, hemoglobin hematocrit. Because oxygen is important at the onset of angina, because our heart is basically being squeezed and is not able to get oxygen and needed nutrients to our tissues. This is why we give our patients oxygen. I hope you have found this recap video helpful, and as always, if you have questions, please ask them.